Welcome to the Metabolic MD. Health means everything. We all seek optimal health, but most of us do not know how to achieve it. Dr. Paul Kolodzik has spent a career in the emergency department. Now, he helps his patients avoid ever ending up there. During these podcasts, you'll learn how you can lose weight and prevent and reverse disease through new technology, a modified diet, and the use of some new recently approved FDA medications. This information is not meant to be medical advice. Please seek consultation from your own medical provider. Let's listen in.
We want to thank our following sponsors, themetabolicmds.com, a boutique weight loss practice focusing on weight loss through modern technology, the latest GLP-1 weight loss medications, and health coaching. We also want to thank the CGM Doctor, where you can purchase a CGM without a prescription delivered right to your door and also find useful information to get the most from your CGM to improve your health and weight.
Well, Dr. Paul, as we sit here, they're debating the big, beautiful bill. This is the week of July, the 4th of July, and you and I have had a interesting conversation that we decided, let's just put this on the air.
Because
right?
we see things the same way politically, right?
We see things nothing near the same way politically. The big, beautiful bill, we don't know whether it's going to pass or fail. They're in the debate process right now. But you are in favor of it failing, correct?
Well, I'm in favor of more fiscal restraint because I am just concerned that, a national debt of $36 trillion. And I don't want to turn people off right from the beginning. This isn't going to be a completely depressing discussion, but we're going to integrate it into when we run out of money here at some point, what's going to happen in healthcare. So we're going to talk about that. But I've been concerned, for 35 years about the fiscal status of the United States.
I agree with you 100% on this. On this, we agree.
There's all kinds of. You can get as deep. You can go down as much of a rabbit hole as you want related to this with, the debt burden we're leaving our kids and grandkids, and the ethics of that.
But you're in an emergency room doc, right? So
right.
Let's talk about the process. Let's talk about what happens. And again, people are probably exploding the numbers. They say 12 million people will be without health care.
Right. So you're talking about the big, beautiful bill, and if they cut back Medicaid.
If they cut back Medicaid, which is what, $1 trillion worth of cuts.
Yeah, I don't know the numbers.
Who knows? What happens? Those people, what happens to those uninsured people?
So we will kind of go back to the days, to some degree, not completely, pre-Obamacare days, and before Medicaid expansion. Obamacare involved a significant Medicaid expansion. And Medicaid, just so the distinction is Medicaid is for low-income people,
right?
Usually also used for nursing home care, but primarily low-income people, as opposed to Medicare, which is for people over 65.
Which I just became on Medicare myself.
Congratulations.
Well, thank you very much.
So, but we're talking about, they're talking about cutting back Medicaid.
Right.
And what'll happen. And this was my experience, being involved in emergency medicine for the last 25 years, is when Medicaid gets cut back, previously during periods where the economy goes bad and unemployment rates go up, people lose their insurance. And of course, that's tragic. Because it leads to limited access to care. People can't call the doctor's office up and get an appointment at the doctor's, or you might have trouble getting a referral to a certain specialist. So that's tragic. But this is the way people access the system when that happens.
So let's just make sure we got this right. They're sick. They're appendicitis, whatever. They walk in the door. They don't have insurance. You're in an emergency room.
Yeah.
There's a rule that says I have to treat them.
Yeah, it was passed back in, I think, the mid-'80s.
Yep.
The COBRA Omnibus Act. And it basically requires medical evaluation in emergency departments for anybody that's presents seeking care. So an emergency department has to see people
No matter what.
Now, yeah, and the term that was used back in the day was you have to provide a screening evaluation for people. So you need to determine if there's an emergency or something serious going on. But my experience again over the last 25 years is that once you get screened, if there's a problem found, then you're going to get the same care as anybody else. You're going to get admitted to the hospital, or the emergency physician will attempt to arrange outpatient follow-up for you, because we don't want to drop the ball on that or be responsible for somebody not getting their problem
So what's the
resolved.
difference between that and having insurance?
So what happens in that situation then is people, again, they don't have insurance, so they're going to get billed for that service.
So there's going to be a bill show up on their doorstep.
Right.
First thing, hey, I can't pay for that. I'm going to go pay it. What
and that's
then?
what happens. A lot of medical debt doesn't get paid. And in the early 90s, when those kind of cutbacks happened, and when there was a tough economy and there were some Medicaid cutbacks, what happens is it just puts pressure on the whole medical system. So during that period of time, that's when we lost a lot of rural hospitals. People maybe remember. That's resulted in the consolidation of hospitals. In our area, there used to be 4 or 5 different hospital systems. Now there are 2. Yeah, that resulted in all that consolidation.
But is that a bad or good thing? I mean, from me, who is just a patient.
I guess you're forced to become more efficient, but the other side of that, from my opinion, from an economic standpoint, is now you got an oligopoly. You got 2 systems, in a geographic area. So there's not a lot of choice, and there's not as much competitiveness to control costs as you would think, or you would see. And the other thing that happens is, in that period of time, it puts pressure on physician groups. Physician groups go out of business.
But I guess this is a thing I don't get, right? We've been doing these this is number 86. We've been doing these for a long time. We never really talked about this. So somebody walks in, they're not insured. They get a bill, they don't pay it. I don't quite understand why there's not like a universal health care like Britain or Canada. What's the harm in that? What if they set that up?
I don't think there's any harm in it, but I think actually a basic level of health care for people would be a great thing.
Just so this is a Bill of Rights for health care kind of thing.
But you got to understand what comes with that.
What comes with that?
Limitations on the care that's going to be provided.
Which got us to a point in the conversation before we started this podcast was, somebody who has like the 11% chance of survival of something, but yet you keep them alive for as long as you possibly can, and that just costs millions of dollars to do.
Well, there's a lot of documentation that the last few months of care, even last few weeks, is where a great percentage of healthcare expense goes. So it's the patient in the ICU that has a decreased likelihood of survival. But then there's just, a lot of time and effort poured into those people, because quite honestly, nobody's willing to say stop. Or that's not completely true. Sometimes I have some very insightful families, some very insightful patients that say stop. It's not worth it. I don't want to do this. Yeah. And that's especially true if the outcome is unlikely to be, a good functioning person.
My wife wants to pull the plug on me now.
Should I encourage her to do that?
You might want to.
But an example is in England. You need everybody here gets dialysis. An expensive process.
Right.
In England, I don't know the exact age, but it's like if your kidney function numbers are a certain level and you're at a certain age, I don't remember if it's 70 or where it is. It's like, you don't get a kidney transplant. You don't get lined up for dialysis. Go home and make plans. We estimate that you'll live about 6 months. So go home and wrap up your affairs.
Are you ready to unlock your full potential? I want to introduce you to the Fit, Healthy, and Happy podcast, a powerful resource to transform your life today. With expert interviews, practical tips, and inspiring stories, this podcast is your roadmap to lasting wellness. Here's what a listener has to say.
I used to struggle with my health, but this podcast changed everything. It's like having a personal trainer, nutritionist, and life coach totally for free.
With over 2,000 five-star reviews, we're a podcast you can trust. The Fit, Healthy, and Happy podcast, available now wherever you get your podcasts.
Well, that might be the smart thing, the financially smart thing to do.
Well, yeah. And again, I think there's got to be some pragmatism here because we have limited resources, and they're going to, my concern, what brought up this whole conversation to begin with, is those resources are going to be more limited as time goes on because of the level of debt we have and the ability of Medicare to continue to finance itself.
So let's talk about the
Medicare and Medicaid.
Getting back to the big, beautiful bill, again, we don't know at this stage.
Can I interject one other thing?
Oh, please interject.
On this whole issue of survivability and chronically ill people and how much resources should be put in, I wanted to mention two things. One is, remember, back when Obamacare was passed, there was this whole discussion of that kind of analysis being done. One of the people in the Obama administration, a doc, Ezekiel Emanuel, Rahm Emanuel's brother, was proposing that we just, infuse some pragmatic decision making into that process. Somebody in the ICU has a 3% of chance of survival and a 0% of functional survival. Let's stop. Okay, no matter what.
So this was the suicide. What wasn't the suicide?
I think they were called death squads.
Death squads
is the term that was used.
Okay, so this is going to be a panel of people in the hospital that would look at each individual case,
which I think is an appropriate thing that should be looked at.
But isn't everything get back to lawsuits? Everybody's afraid to be sued.
I think that's some, but now think about how AI could be used in this context. I mean, you can plug all the data into AI and come out with, pragmatic, really objective findings of likelihood of survivability or functional survivability. So it really takes it almost out of the realm of, a panel of people or a committee deciding what to do into an AI realm. So I think that'll come at some point. I don't know if it's 3 years from now or 15 years from now, but I think
make a great movie when you think about you're plugging your numbers in AI and you got to go tell John Doe, hey, AI said you're not going to pull through. How would you like to go? But again, this gets to another conversation. Assisted suicides. A way of phasing out.
I don't think we're talking about assisted suicide. I think we're talking about withdrawing care,
which just lets you go out on your own.
Yeah, over time. I mean, it could be an assisted suicide discussion, but I don't want to go there in this conversation.
All right, so where I do want to go is okay. Again, the big beautiful bill is being debated as we speak. And there's tons of people wanting to kill or defund Medicare to a large degree. Medicaid, sorry. But somebody's going to pay for something somewhere. Where does the money come from eventually? Because if you're going to get the health care anyway, because you're going to show up at the emergency room, they're going to treat you.
Well, I think the system will just get squeezed like we talked about.
But who pays? I don't get it.
Well, so what happens is when, fewer people are insured, that results in the hospitals and the physician groups getting squeezed.
Squeezed from a financial point of view or staffing point of view, or
yes,
both.
Yeah. I mean, they'll from a financial point of view, they'll get squeezed.
So instead of paying $15 for a Q-tip in a hospital, I now am paying $19 for a Q-tip because there's inflation in there.
I think there are limitations on that. Well, what happens is resources get cut back. So you talked about staffing.
Yeah.
So a lot of the cost in a hospital is the staffing, primarily nurses and some physicians, but let's talk about nursing. The nursing staffing will be cut back when that squeeze occurs, because that's one of the great expenses of the hospital. So what does that mean? There are fewer beds available. Way back in the day when somebody said, "Oh, the hospital's full, we don't have a bed in the hospital," there literally wasn't a bed. Nowadays, when there are not beds available, really what it means is there's a wing of the hospital that has plenty of beds in it, but we don't have the nurse staffing for that, or we don't want to pay the expense of the nurse staffing. So this happens to me currently at the facility that I work at. The facility will be full, or in some cases we don't have the right specialist at that facility. And so I have to go shopping for somewhere to transfer the patient to.
Yeah.
And again, we got a couple big systems in the Dayton area, but I will call at times and they'll say, "Sorry, we don't have any availability."
What was the hospital called back in the old days where people of low income or no income would be sent to? There was
They were county hospitals.
County hospitals.
Yeah.
But they've done away with county hospitals because of the consolidation.
Well, there are still some county hospitals that are partially municipally owned as not-for-profit.
So is that where these people will end up going, to a county hospital?
Look at in our locale and in most locales, there are not county hospitals anymore. They'll end up going, basically a lot of times to academic institutions, university medical centers, or like in our community, it's basically going to be to one of the healthcare systems, one of the two healthcare systems, and the resources will just be cut back in terms of, whether people can get a bed in the hospital. A big issue in emergency medicine over the last 10 years has been emergency department boarding.
So let me ask a question about somebody who's diagnosed with cancer. God forbid, I'm knocking wood here, right? What happens to those people if they're not on any kind of insurance program, Medicaid, or if
they still get care?
How do they get it?
Well, they come in through the emergency department.
They have to come in through the ER. They're not going to be able to call up the hospital.
Well, sometimes, yeah. So, the question is, do they have a relationship with a physician on the outside, and is that if a lot of even not-for-profit health system medical groups take only a limited number of non-insured people. So there are still public health clinics and that type of thing. And then the doctors and the administrators at those public health clinics will do what they can to get that patient care. But that can become a challenge if they need a certain type of specialist and that specialist is full or no longer taking, certain types of insurance. There are specialists that just don't take Medicaid insurance.
I just don't get it. I guess this is why it's such a hard thing to solve, because if you're not going to insure them, but they're going to get insured, they're going to get coverage anyway. I don't get it.
Yeah. It's not really the best system because, again, people wind up in the emergency department. The saying in emergency medicine since the beginning, think about it. Emergency medicine's only been around since the late 70s.
Yeah, we did a podcast on this.
Or early to mid 70s or so. But the organization I belonged to, the American College of Emergency Physicians, was new at that time. And one of the phrases, not formally, that used to be thrown around was no shirt, no shoes, no problem, which means basically we'll take care of anybody.
Yeah.
Yeah. And the emergency department is still a place where anybody can get taken care of. And I'll, Terry, I've been doing that over 25 years, and I still enjoy doing it. I still enjoy taking care of people and helping them basically solve a problem.
So let's spend the last 3 minutes of this to sum up kind of where we differ, right? I don't believe we should be spending $1 zillion on 30-ton bombs, right?
Or tax cuts for the wealthy.
Or tax cuts for the wealthy. I think we should be investing on things to help people that need help. Yeah. But I don't know where you fall in that gamma.
Well, I think people should have access to a basic level of care where they don't end up, basically having, a bill due potentially forever, wages garnished, all that kind of stuff. There should be a basic care level of care. But I think we do, related to the fiscal constraints we talked about early on, we're going to have to come to some reasonable approach in terms of really what we have the resources to provide, like other countries have. In England, in Canada, et cetera, there are certain, levels of service,
right,
that they don't reach. And that's why a lot of people come from around the world to the United States for medical care. So I think everybody should get a certain basic level of care. But I think at some point we're going to have to limit that we can't do everything for everybody. And, that's going to result in the dreaded two-tiered term that's used, the two-tiered medical system, the basic level of care for everybody.
Yeah.
But then people that have extra money, or can afford extra insurance, and this occurs
That's
in
kind of
European
Medicare
country.
Because I bought the Cadillac service with Medicare. Right, you got Medicare, and then you buy these supplemental.
Do you
things.
feel guilty about that?
No,
Okay,
but
that you're getting a higher level of care than other people.
if I want to spend my money doing that versus buying gin and women, you know.
Yeah.
So I felt I wanted that because I wanted that protection, but to give some level that you get right out of the bat,
Right.
makes sense.
It makes sense, but it's not, it's not happened in this country except for what Medicaid is now for a majority of people.
Well, okay, we should do a follow-up podcast 6 months from now, which will be in Christmas time. Go ahead.
I want to get the health and wellness angle in here.
Oh yeah, we need some angle to plug. Go ahead.
Which is nobody's going to care more about your health than you. And about 70% of medical problems are preventable. Sometimes you just get unlucky. You get in a motor vehicle accident and get injured, or you get a type of cancer that your lifestyle didn't have anything to do with. You're unlucky. But 70% of disease is controllable by watching your weight, watching your blood sugar, maintaining healthy activities. So nobody's going to be a better advocate for your health than you, and nobody can do more to ensure your long-term health than you. And that's really why, I've had the metabolic health practice over the course of the last 10 years.
All right. So next podcast, we will talk about the RFK wearable thing. I think that'd be an interesting podcast. We didn't get to that today, but
Can we give people a preview on that?
real quick.
Okay. So RFK is a big proponent of wearables, and we're talking about continuous glucose monitors here for the purpose of this discussion. And of course, I've been involved in that now for 5 years because
You wrote the Bible on
CGMs.
CGMs,
yeah. Go to Amazon. Best-selling book on Amazon.
Oh, yeah.
On CGMs. Yeah. So RFK has come out as an advocate of these, and quite honestly, I think for people to get a CGM on for a couple of weeks and just see what's going on with your blood sugar physiology can be eye-opening. In some of my patients, it's been life-changing because they realize they're in a pre-diabetic range or heading toward having severe insulin resistance. So I think his comments really were appropriate. You can get a CGM over the counter now for $50 for 2 weeks. And so I think it's a great thing. But he got a lot of blowback because of, the thought of, this is just going to be the government collecting data on us. Now the government's going to know everybody's blood sugar, which I'll tell you, having used CGMs now for years, the government, it's HIPAA controlled. The government doesn't have access to your CGM data. So I agree with what Kennedy said. For anybody that can get a CGM and wear one for a couple weeks, and I disagree that it's the government collecting data on you.
All right. Well, we'll come back. That would be a great little topic to cover. All right, folks, this has been the Metabolic MD /CGM Doctor with Dr. Paul Kolodzik. We will see you again real soon. This is probably going to be airing sometime in August, so we'll know by then what the big, beautiful bill happened or not.